Hey guys, welcome back for another episode of the AltMed Podcast. Really appreciate all your love and support to date. We're seeing the view counts go up on our videos and we absolutely love that. So tell your friends, tell your family. We hope you guys are getting a lot out of it. If you are enjoying it and you maybe only listen to it for the first time or whatever, just please hit subscribe on whatever channel you're getting this feed in. Really building a community here. So whether that's YouTube, Spotify, whatever, please hit subscribe and give us some love. Well, with my co-host, as always, Mitch Kurtz, today we have the pleasure of speaking with Dr. Joel Wren. He is a GP based in Adelaide who is well and truly making a name for himself as a specialist in cannabis medicine in Australia. So Dr. Joel, welcome to the podcast.
Thanks so much for having me, guys. It's an absolute pleasure to be here.
That's great to have you.
It really is. There's so much that I want to dive in and tackle today, but maybe before we do, can you maybe talk us through your background and how you found yourself as a cannabis doctor?
Yeah, it's a varied and interesting story. I studied medicine in Queensland, where I grew up. I met my wife in medical school, and in order to actually get to the same hospital, we went a little bit more rural after we graduated. So I went up to Mackay for a couple of years. After that, she got her foot in the door, funnily enough, down here in Adelaide in South Australia. So we up sticks and moved. I have been in the community general practice medicine for a couple of years. And, late one night, I was just actually having a look at the classified ads, and I saw an ad for an up and coming cannabis clinic. And I've worked in hospital medicine, I've worked in general practice, and I'm acutely aware of how much cannabis is being used by and consumed by the community. So I knew that some people used it recreationally, a lot were using it medicinally, and I thought, okay, maybe this would be an interesting area of medicine to get involved with. And I started part-time, and it just absolutely blew me away. I spent months and months trying to convince people to take medication for their blood pressure, and they still wouldn't, whereas something like cannabis, they just couldn't get enough. I had never seen that level of enthusiasm or engagement with something like cannabis medicine. And I was hooked ever since.
Yeah, right. That's it. We do hear that a lot. We hear that people, when you think about, especially when you in the context of people who try to negate the effects of cannabis or say that it's, a bit of hippie kind of magic, if you will, like some of the pain specialists in particular. And then you look at the price and the difficulty of access, and despite all that, the overwhelming demand for cannabis products, it doesn't seem to match up if you really think it doesn't work. I think in the community, it doesn't really, it's not congruent with the amount of demand and how much people are willing to pay through the nose and, go, sometimes months trying to figure out how to access the product.
Yeah, absolutely. It's certainly not the perfect thing for everyone, and that's a really important distinction to make. But it's something that has brought so many people back to the conventional healthcare model and modern medicine that essentially has failed a lot of people in the past.
Yeah, very interesting. Out of curiosity, and I think this is always a really good place to start when we have GPs on the show, but the top 3 questions, or like the main thing that people ask is, as soon as they walk in your door, you meet them for the first time, what are the 3 most kind of questions that everybody asks when they come in as a patient?
About medicinal cannabis, or just as a GP patient?
Well, maybe we'll gear it more to the medicinal cannabis side on this particular one.
And that's probably one of the really titillating points of meeting people for the first time. Without trying to actively advertise myself, a lot of people through word of mouth alone are now becoming aware that I do prescribe. And so seeing a patient for the first time, they'll sort of they'll dance around it, and they'll sort of
you're
they'll
Adelaide's biggest dealer all of a sudden in there.
Yeah.
That's what's really going on, isn't it?
come see me at no. But it is one of those points of they've brought it up with their usual GP, or they've mentioned it in passing, and they've sort of been shut down, and so they've come in and said, oh look, I've heard that you're really interested in something, or oh, I'm looking for something more natural, and so I kind of just address the elephant and say, oh, would you like to talk about cannabis? And there's almost just this weight of relief of, yes, we can talk about it. I think some of the questions, firstly, are it doesn't have that stuff that gets you high, does it? And that's obviously a whole other discussion there. There are some concerns about price, but it's really an interesting sort of double-edged sword, where a lot of people are making their own oils, saying, oh, I've got this oil, is that okay? And so I think that that's something else where there's so much confusion, and especially with online markets, it's really tough for patients, young and older alike.
Is it? Yeah. I have a question about the patients that are maybe taking black market products. Do you ever find that they might bring that into the clinic and say, hey, this is what I'm actually taking, but I want to have something that's legally prescribed. Can you give me an equivalent product? Have you had that experience much, or is it more, yeah, okay.
I have had a few patients come in, and I think that they've been sheepishly pulling out a bit of a tin, and I think, oh, hang on a minute, what's going on here? But I think that's actually one of the things that I was really quite interested in initially, knowing that people take it, but they don't actually have access to home testing kits. And I know that there are a couple of online communities trying to expand that, because it's one thing to be taking it, but it's another to actually know what you're taking as well. And you want to make sure that, I mean, not even from from an active pharmaceutical ingredient perspective, even just from a toxicity perspective, because that's what a lot of people forget as well about hemp and cannabis and the actual plant itself. It is an absolute sponge. So it sucks up so much or so many nutrients, but also so many toxic compounds as well, that if they're using it, they can actually be ingesting all sorts of mess.
Yeah. And that's why we, even for the large majority of products which are deemed by the TGA to be, quote unquote, unapproved therapeutic goods, we still have TGO 93, and we have that Australian standard as a sort of baseline for quality, which is, I guess, one of the reasons why when I talk to people that are using black market, it's, look, it might work, but you just don't necessarily know what's in it. But yeah, on the clinical side, what is, when people do come to see, what are some of the more common indications or medical conditions that people are presenting to you with? And can you share maybe some of your clinical experience with medicinal cannabis?
Yeah, sure. So I've seen lots and lots of people for lots of different reasons. Probably the main ones that come to mind are absolutely chronic pain, and even within that, that's so varied, because you've got chronic unexplained pain and fibromyalgia, which again brings a lot of stigma of its own that people have struggled with. But certainly compared to your inflammatory conditions, rheumatoid arthritis, Crohn's disease as well, and even something like endometriosis is exceptionally common, and a lot of women get absolutely vilified because it's not a visible condition. It's not something that we can really easily do a blood test for and confirm. So it's, even with something like that, it's diagnosed late. The treatments do have side effects, and especially contraception as well. So a lot of young women struggle with something like that.
That's an interesting one. is it, and lots of pain, I imagine, in the sort of the early stages of that particular condition. But is to your point, you're saying that actually doing the diagnostic activity to determine that particular condition is often fraught with some issues. Is that?
Yeah, absolutely. So it's something like endometriosis, or just endo for short. It can affect, I think, the latest figures are up to about 1 in 10 women, and that's a lot.
Yeah.
And it's a big journey to actually get the diagnosis. Probably one of the reasons for that is to be 100% certain, what we call the gold standard of diagnosis. It's a surgery, and actually a diagnostic laparoscopy, going inside, actually having an internal look. So obviously that's not the cheapest test to confirm something.
Yeah.
But it's within these women of starting their periods, exploring contraception, struggling with lots of side effects, and 10, 15 years later, they suddenly realize, oh, hang on a minute, it's not normal to lie in bed 1 every 4 weeks, just curled up with a hot water pack against your belly. I've had patients that it affects how their subcutaneous fat looks. It actually they get almost scarring from holding on to hot water bottles for that long, just because they're in so much pain.
Yeah, wow. Yeah, I know there's women in my life that definitely find that medicinal cannabis, particularly some full or broad spectrum products, play a major role in the mitigation of cramps and menstrual cycle, or just general female reproductive health episodes. So I've seen that secondhand, I guess. But yeah, and also another thing I've been reading about of late, is quite all the rage in America, is the experience of sex as a female. So there's obviously something going on. I believe there's CB receptors on the endometrium and on the ovaries. Is that correct?
Certainly internally, yeah. And it's there is evidence that a lot of women do actually use it to enhance their experience as well. And even to come back to endo, that is one of the cardinal symptoms in having painful sex, because it's just so pervasive. So something like cannabis, it can be a wonderful product, because not only do they or can women use full spectrum high CBD products throughout their regular cycle, and keeping their inflammation down or suppressed. During their natural menstruation, their actual period, they can absolutely switch over to a little bit more THC, have that vaporized product on hand for that breakthrough pain, and as their cycle changes, so too do the cannabis products that they use, which is it can be really, really life-changing.
Yeah,
that's a really that brings me to, I guess, to a broader point, just from your experience as a doctor, given that, we're dealing with these products that we're still seeing so much clinical research being done, but we have all this anecdotal evidence. How do you go as a doctor prescribing, as you said, you have adjusting therapies depending on what stage of the cycle for women? Do you have many patients who you might prescribe both sort of a high CBD and then maybe a separate product? And are there any difficulties you face in prescribing multiple cannabis products? I'm just interested.
Yeah, for sure. So from a regulatory point of view, to be honest, it's a huge pain in the ass. And I understand that government stance of patient safety, for sure. At the end of the day, that's what everyone wants, but it's a difficult thing to try and explain that nuance of we're aiming for approvals for 3 separate products, one containing THC as an oil, one that's high CBD, and then having maybe a third as a flower, whatever. But trying to say they're not all taking everything all at once. It is being implemented in a proper management plan. But in saying that, my approach, to be honest, I always remind doctors, patients, whatever, it's not absolutely magically new. It should be replacing what we're already doing anyway. So with a typical pain management plan, it's not uncommon to have your baseline. I mean, for endo in particular, having a baseline contraceptive, but then also having your breakthrough, and this is the difficulties with opioids. So your Panadine forts or your endones and strong opioids that they're only used for a week, a month, or whatever it is. One of the things that can be quite difficult, that certainly gynecologists can attest to, is it's trying to actually anticipate pain, because we know that a period may be coming, so that we know that an extra level of pain may be experienced. So it's just trying to catch it early rather than trying to play catch up with it.
And curiously, we hear a lot about opioid side effects. What's your experience with patients and side effects to medicinal cannabis, or females with endometriosis that might, as opposed to males with endometriosis, that might actually experience side effects? Do you find that there are few, not many, or quite a few, or I'm not sure?
Yeah, so there's boatloads of side effects from the opioids, and that's never nice. And I mean, it wrecks people's bowels, which are fickle at the best of times for endo. With cannabis, it's the most common side effect that I've seen from cannabis is probably just a bit of fatigue, and they just slow down a bit. But generally speaking, on the whole, the most common response that I've gotten from women using cannabis for their endo is they feel like they have their life back. It just, they are so much more active than they've ever been previously.
Well, that picture you were painting before with the hot water bottle, and I mean, that is a terrible thought that anyone should be just experiencing.
Yeah, it's horrendous.
That level of suffering is ridiculous. But just back on pain, and I'm going to, sort of pick your brain a little bit about the work that you're doing as Vice President of the Society of Cannabis Medicine. I hope I got that name right, but
clinicians, but that's okay.
Yeah, but I just wanted to say there's been obviously reports in the media from different sectors within the medical community, and there was, I think, an article which is still being talked about, which featured I think someone quite senior at the Australia New Zealand College of Anaesthetists, quite an experienced pain medical practitioner, and he sort of offered the view that he's not recommending cannabis medicine to doctors to treat pain because there's just not enough evidence. And I know that that opinion seems to be dividing the medical community. I think I've got a sense of where you might sit with that one, but have you got any thoughts on that without sort of inviting you to into too much controversy or anything?
Yeah, and look, I'm not going to wave a flag and say, oh, these guys are terrible and they don't know what they're talking about. Look, anaesthetists are absolutely specialists in what they do, and they do have their own skills. I absolutely, if I need their help, they're the first to be called on, and they're great. It's just frustrating that the way in which they send these messages, it really it creates its own controversy, because it further stigmatizes patients and they're less likely to engage with the conventional model. It deters other clinicians to learning about it, and that's not prescribing, that's learning about it in the first place. It's looking to the specialty college and hearing them say, don't bother. And then they sort of shrug and think, well, why would I bother learning about it if it's not useful at all? And there's no nuance. There's no subtle discourse about, well, look, we're not the hippies pretending it's going to cure everything. It's recognizing it as a tool like anything else that we use. And the message that I've sent is the gold standard for treatment is an MDT, a multidisciplinary team. And again, nobody's doubting that. But in the real world, with people in the community and accessing these MDTs and these pain clinics and getting routine reviews, it is really bloody hard.
Yeah. And it's, I couldn't agree more. I think as well, just that the point of if you've got, heavy duty opioids that are being used, and that level of dependency that they create through opioid addiction. And you talked earlier about the damage that these drugs can do with prolonged use to the bowels and other systems in the body. I just don't know why we're not at least open to considering cannabis medicine, given it doesn't come with all of those things. I don't know anyone who has used CBD and THC and developed a genuine harmful addiction that is ruining their digestive system. So I would like to think that there's at least enough doctors out there that can sort of say, okay, the opioids might be registered medicines in Australia and have that tick, but we need to consider all of the holistically, what is the person's health outcome if they use that over a really prolonged period of time. So I guess in that vein, I'm very glad to see the Society of Cannabis Clinicians popping up and actually lending a different view.
It's I guess it just speaks to a broader issue. And I mean, working as a GP, it is one of my sort of bugbears where the specialist will have their opinion, which 100% they're entitled to, but to be able to translate that to the patient and to continue their care, the specialists and certainly anesthetists are now turning away from opioids because they're recognizing, okay, that it does have serious harms. That's great. And they see the patient every 6-12 months and say, no, we should be aiming for this. It doesn't mean that the patient isn't still seeing me, every other week of, I'm still in tremendous amounts of pain. What can I do? What can I try? And without having an option like cannabis to work in to everything else, to their exercise plan, to their psychologists and their psychotherapy, it's infinitely maddening.
I was thinking back to late last year. I got some shoulder surgery done due to some misadventure on my part on the footy field. I think I got 2 touches across 3 games of footy. So
one of those touches was on your shoulder, actually.
Definitely not a best on ground performance, but I went in for some shoulder surgery, and just before sort of getting to the operating theatre, I have a quick chat to the anaesthetist, and he said, I'm going to prescribe you some endone for after the surgery. It's, be very low dose, just 5 milligram. And it's really for that breakthrough pain that you're going to experience perhaps in the aftermath. But given it's keyhole surgery, I think you'll be fine. But really important that you don't take it for longer than about 10 to 14 days, because that's when your body actually begins to develop a dependency to it. And I was really, not that I had sort of intended to take it for any longer than that, but I'm glad I had that conversation with him, because what I found was when the medicine actually was given to me in the hospital post-surgery, I read through the consumer medical information, the CMI sheet that comes with it, basically because I was bored. I had nothing better to do in hospital. And I was looking at it, and it didn't say anything on there about, you should try to stop using this after 10 days. And to me, I'm thinking that's really dangerous. If I've got an anaesthetist telling me you could become addicted to this medication if you use it for that, but the medication stays completely silent about these things. And it's an approved medicine in Australia. Anyway, definitely pointing my finger at you, Main Pharmaceuticals. I was very disappointed in that, but a little bit of a side note. Yeah, sorry.
Well, again, it speaks to that subtlety. It's something where we know that it's good for acute pain, but over time, building tolerance, it can actually make people more susceptible and more sensitive, so that any level of irritation causes this augmented worsening pain reflex. And the one positive is that the TGA and the PBS rather are actually changing some of the indications, and so they are trying to reduce that indication of, oh yeah, opioids for chronic pain. Well, no, they're changing it. They're not providing an alternative, but they are at least slowly addressing the issue.
I think my biggest gripe with the said anaesthetist coming out with that statement was not about, it was the way it was said. It was not, the evidence suggests that medicinal cannabis doesn't work. It's just that there is no evidence. So that really speaks to the fact that mainly the studies haven't been done. Because if the studies had been done and it showed a negative correlation, then that's a different story, obviously.
Yeah.
So, yeah.
And that's to speak about the actual inception of the Australian chapter of the Society of Cannabis Clinicians are typically, well, it was born out of the US, but it was founded on the back of Lucy Haslam and Gail Wiseman, who came to me about my statement that I made to the Commission of Narcotic Drugs and the WHO actually rescheduling CBD. And through that lens, having a look at the history of cannabis within the 20th century, it is night and day how, or at least black and white, how politicized and how far removed it was from the actual science. And academics jumping up and down saying evidence, evidence, evidence. I mean, number one, there's a huge issue about reproducibility in the scientific world in the first place, and the dictum of publish or perish is making evidence-based medicine a bit of a farce anyway. I'll get off my soapbox. But the bigger issue, but the bigger issue is how can you say that there's no evidence for something that has been under lock and key for decades? And even with other more natural alternatives and psilocybin and things like that, the paperwork involved to actually get pharmaceutical grade products to then be able to study it's absolutely, like, it's insane. It's absolutely insane. So yeah, you're right, Mitch, just this flippant, there's no evidence.
Yeah, well, yeah, and that actually is, I think it was Rick Doblin, or the guy who's sort of been behind the MAPS studies, across a lot of countries, looking into, the therapeutic effects of psilocybin, MDMA, these types of substances, which have been caught up in this political firestorm. But they talk about, I think he described how in the sort of the early part of the 60s, psychedelic medicine was actually a really booming research field. So there was a lot of labs around America that were actually examining different substances, and all of a sudden, just overnight, the laws change, these become outlawed substances, and all of that research just sits dormant for 50 years. And then it's
was part of the patient cohort of Woodstock that actually might have contributed to part of that. I'm not sure.
Yeah, and they're just sort of like, they're picking it up now and saying, all right, well, let's just pick up where they left off, 50 years ago. But sorry.
Interesting. It brings me to a question I actually have for Joel. Like, when you talk about the difficulty of actually finding, the right studies or the education piece as a doctor wanting to, I mean, I guess it's coming a bit more to the foray at the moment, but how difficult as a GP is it to get into cannabis? So we have quite a few members of the professional society that tune in from time to time. And I'm just interested in addressing, somebody maybe sitting on the edge and haven't really done too much cannabis scripts, or they've heard about it, they don't really know, but some people ask them, but then they refer them on to other clinic or a specialist. If they want to take the plunge, how difficult is that to actually get involved?
It's not at all difficult to start. It's I'm not going to lie, it can get very confusing, and that part of the reason for that is the being unregulated. But I think that that's exactly what the Society of Cannabis Clinicians is for giving resources, for giving guidance into what's reasonable and what's not. It From a safety perspective, cannabis is incredibly better than a lot of the other medications that we use. So even if it's just one or two patients, even if it's discussing things with your local health department or understanding the steps involved, there are so many resources available. We'll be coming out with our own educational course soon. It's absolutely there if you look for it. If not, by all means, I'm happy to help them out, and certainly the society is as well.
What a guy.
No, oh, sorry, you go, Mitch.
No, I'm going to take it on a whole different tangent, so you better get that question in.
It was. I'm going to sneak it in. It was just about the society's work. So you are rolling out, I think, training materials and programs for doctors that are interested in getting on board. How's all that going? And are you doing that virtually? I know a lot of GPs who have expressed an interest in starting to look into that space. So if there are any listening, maybe if you can just quickly tell them about what you're doing.
Yeah, certainly. So there's the United in Compassion symposium on the Sunshine Coast this August. There will be a general admission and stalls and lots of specialists and international speakers, doctors, both again international and local.
Have you invited that senior guy from the ANZCA who made the comments about recommending that his doctors don't prescribe cannabis? Did he get a complimentary ticket?
I'm not sure, actually. That'd be an interesting. Yeah, we'll
be an eye opener.
Reserved seat.
Yeah, front row.
But I'm not sure that the organisers would be quite keen, given their previous thoughts on it. But there is actually also a healthcare professional training course on the, I think it's on the Sunday, and it is pretty much, you can walk in with no knowledge at all and hopefully come out the other side with a better understanding, not an expert level by any means. The online course that we're looking at the moment, we're just trying to run that through the RACGP accreditation, because if we are offering things like that, we want to make sure that not only is it good quality, but we're always getting the ever needed CPD points for it.
Great.
Yeah, fantastic. All right, my turn for taking it on tangent again. I know there's one other area of interest that you have, and I really would like to just briefly talk about it. Sleep.
Yes, I tend to put people to it, and it's great.
What about as a doctor?
Well, it depends. Ask my wife. No. It's an interesting point that you bring up. So I've obviously seen lots of people with lots of different presentations and syndromes and reasons for their issue, but I think by far and away the single biggest improvement that I have seen, regardless of pathology, has been in patient sleep. So whether or not that's being so anxious that they're anxious, their thoughts are racing through their mind the second that their head hits the pillow. I've seen patients that have insomnia and get anxious about their insomnia, so that they're anxious to go to bed that night. And it's this terrible cycle. It just worsens, compared to people with just awful back pain where they can never get comfortable. They're tossing, turning, they're cursing, they're all sorts of things. Almost across the board, some form of cannabis has actually improved it, and it may not actually be removing their primary pathology, their main issue in the first place, but absolutely it steals them a bit. It gives them a better reserve where, yeah, they're a little bit more anxious, or they're a little bit anxious and they're stressed, but they're a bit better rested so that they can deal with it in a more productive way. They know that they still have their pain, but they're a little bit happier, again, a bit more refreshed to then be able to deal with it. So it's I think that's one of the hugest improvements that I've seen from a lot of my patients.
And I when you're talking about medicinal cannabis working for sleep, are you saying is it more of a CBD, more of a THC? Are there, in your experience, what's the kind of ratio, or which direction do you take it?
Yeah, I'd say CBD long term, but at the same time with sleep initiation, especially THC, and that's starting to move into. Medicinal cannabis isn't just oil as well, and that's something that a lot of patients or doctors and lots of people forget. Where having a safe, decent device to vaporize it, absolutely they are able to get to sleep within 20 minutes, whereas a couple of weeks ago it took them 3-4 hours.
Who knew that, Mitch? You and I were ahead of our time. We were vaping THC quite some years ago, and
we'll say that's in overseas, because that's
absolutely. Never in Australia, never.
True pioneers.
Not about pioneers, but we're good at sleeping, I can tell you that much.
Pioneers.
But I have heard though the THC can actually interfere a little bit with REM sleep. Is that something that you come across, or?
Yeah, look, it's on my radar, and it's certainly it's something that I'm careful with, and that's why, like everything, it's important to have your regular clinical reviews and making sure that we're not messing with that architecture. So I know that it's theoretically possible, but at the same time, it's what's the delivery method, how long is it lasting, and whether or not that's actually being balanced out with CBD to actually act as that modulator, to try and reduce any risk there.
I mean, it wouldn't be an issue for Andrew, who's got delta waves even when he's awake, so it's not really.
I just need my vaporizer, some THC flower, and hopefully a Nintendo Wii so that I can play some Mario Kart as well. But Mitch remembers it well. I was going to ask just one thought that occurred to me as well. I don't know if we've touched on the podcast, just the kinds of delivery formats for clinical consultations and what attracts the Medicare rebate. Are you able to maybe just talk us through that? Because I know we are moving into telehealth and virtual consults, but how does
especially in lockdown Victoria?
Yes, we're coming to you live from the gated community of Victoria. But yeah, if you can run us through that, that'd be great. Yeah, I think that the telehealth initiative, previously and last year, it was wonderful. It certainly did get us through tough times, both from a GP perspective, where we weren't given the proper PPE. We were unsure how to take swabs and to expose ourselves unnecessarily. So it really was a fantastic lifeline. One of the things that a lot of people forget is that the second that we are claiming through Medicare, we have to explain ourselves to a much, much higher standard than usual typical consults or entirely private consults. And that's mainly, it's because of how they have set up their what's required and their own sort of internal justification. Sometimes it makes sense. Other times it's, for a skin excision, do we really need to take all of their vital signs every single time? Well, I mean, they walked in and they were talking to us. They're pretty conscious, so I think that it'll be safe. Yeah. With telehealth in particular, there's the RACGP at least were feeling a bit undercut by some of these instant clinics that were popping up. And there's a fairly good reason for that, where we want to make sure that if patients want care, that they're getting it from somebody who knows them or somebody who knows their history, that really can't be communicated effectively in a 5-minute phone call.
Yeah.
And so there are these restrictions where, yes, you can claim the telehealth item numbers through Medicare, at least temporarily now, in the right circumstances, if you have a previous relationship, or if, for example, with the lockdown, it's, you're not able to get out of the house, so a phone call may be all that you can do. So it was interesting when it all actually started, I had an English colleague who was shrugging, saying, I mean, it's a norm over in the UK, and it can, save a GP's day. Instead of doing a house visit or doing all these extra things, it really is a matter of convenience. So in what form they continue it, it'll be really, really interesting to see.
And I'm guessing things like, we're not at a stage where you can do, say, text-based consults or anything in sort of like a live chat, any of that sort of format. Do you see any of that popping up at all?
It's interesting you mentioned that. I'm not sure how I feel about being catfished by a patient.
Well, the thing is that it always be, at least it's all in writing. As a lawyer here, I'm all for that.
ASL question mark?
Yeah.
No, I think that it does, again, speak to a broader point about certainly safety. And even with telehealth, and I do conduct video-based consults online, it's not always the safest option. And even APRA, the health regulator, they've actually come out and said, they released a telehealth guidance document all the way back in, I think, about 2012 or something, like really a long time ago, all things considered. But their first point was, is this appropriate? And so, I've had phone calls of, I've got a rash. That's not appropriate. I can't assess it. So it's, in some cases it's convenient, and cannabis, it certainly is convenient for most of the presentations, but it's not without its own drawbacks as well, for sure.
I guess that might be one of the reasons it does lend itself to some of the more, I guess, what they consider subjective conditions such as pain or anxiety. It's not subjective to the person suffering, but if you get what I mean.
Yeah, mental health is a huge one, and that's why I actually prefer video, like online stuff as well, even for mental health, because it's convenient. I've got patients sitting in their bed, still wearing their PJs. But at the same time, it's face to face, and they can actually see me, and I feel as though I'm connecting with them. So for that, it's a huge bonus.
Yeah, interesting. And is it likely then that, I know they've got these temporary Medicare item numbers for telehealth, but it's a bit of guesswork to know whether or not that's here to stay. They might go back to saying, all right, patient X, if you want the Medicare rebate, you have to do an in-person consult. I mean, yeah.
Yeah, it's like any sort of Medicare item number, it'll be lots of back and forth between the government, between the RACGP and, relevant stakeholders, as always. So I think it will get done, but probably not until the 11th hour.
Yeah, as always with government policy.
Mm-hmm.
Well, I've exhausted my list. I know that the moment I get off this call, I'll have another 5 questions just flood in. But Mitch, did you have anything else for Dr. Joel before we wrap up?
Well, you already know what I'm going to ask. Maybe I'm going to let you do it this week. The final thought question.
Final thought of the day. Mitch is always asking guests on this podcast the age-old.
Don't worry, I'm a size 9. If you're wondering.
Oh, no, I don't even have to ask anything.
Well, that's it. Done. We've got you 2.
Oh, cool.
We wrap this up. No,
what about 2s? The question,
The question,
I guess,
sorry,
is,
I was asking.
well, it's if and when.
Okay, yeah. If cannabis, or I think it's a when, but if medical cannabis, well, sorry, if cannabis rather becomes becomes recreational, when might that happen? We do ask you to give us a year prediction, if you wouldn't mind.
Yeah, okay. So as in like an American model, like an alcohol model?
Well, let's not use American model because it's still not actually legal there technically.
Yeah, that's true. That's true.
Like a more Canadian model, maybe. Oh, some people choose to split it up between CBD and THC. Some people just say full rec.
Up.
You know. Sorry?
Spliff it up. Sorry.
Yeah, split it up.
Look, I would say it's a great question. I would probably say 2028.
Okay.
Yeah, I like you thinking there.
And I think it's something that obviously we can talk for hours about it. I think that the recreational users are hurting the medicinal users, and I think that there's a good proportion of recreational users that are medicinal without realizing it. But I always have to go to the lowest common denominator, and it's sad, but there are going to be people who will misuse, and it's as simple as that. So it's
for sure.
For sure.
As there are with alcohol, with
100%.
Yeah.
So I would hope that there's that separation of the medicinal and recreational crowd that at the moment just seem to be smushed together, and I think that's a disservice to both of them.
Yeah, I agree. And when I remember when I was living in America, and one of the first things I noticed in typical American style, they like to take things to the extreme, but the products that they were using were no longer, it was like a highly concentrated synthesized cannabis product. You're not talking about, you know, a joint or something in the kind of 5, 10, 15% kind of ratio, 20 even. You're now talking about, have you heard of dabs?
Yep.
Shatter, dabs, these concentrates that are essentially, you know, 50, 60, 70, 80, 90% THC, and you're using them in
what is it, Mitch?
Like
equivalent of doing, like, you know, ABC shots at a bar where you get the absinthe, the Bacardi 151.
More like methylated spirits. It's
right down
isopropyl. Like it's actually pretty intense. Like, and if you're doing that regularly and chronically, you can see that it's like the heroin of cannabis, if you will, in a way. And again, you know, the toxicity or the level at which it could be fatal is still, the jury's out, but it doesn't seem like it's at any kind of amount that we haven't seen it happen, put it that way. But these guys are really testing that theory over there.
A lot of anecdotal research going into this.
Well, observational.
Yeah.
It's a shame. It really is. And I guess, like, it's, you know, it's people's rights to sort of do what they want, but yeah, it's always that safety. And I'm certainly trying to be that scientist, that physician of, hey, if it can help, if people want, you know, I mean, maybe more of a vape to wind down rather than specifically a joint, but if they do just want it in the same way that they'd have a safe glass of wine, then hey, the whole world won't stop either. That's okay.
Yeah.
Yeah, and I'd probably, to be honest, prefer to have a little bit too much to vape than have a little bit too much to drink, to be honest, in terms of the way you feel the next day, the way you feel on the night, maybe, you know, and the risk to health. You know, I've never heard of somebody getting their stomach pumped from THC.
Yeah, that's clearly your night wasn't big enough, but
yeah.
Anyway.
Yeah, donuts and Krispy Kreme.
Exactly. Well, on that note, want to thank you so much, Joel, for coming on and having a chat to us. Your insights are just amazing, so fantastic as well. Just to see that, you know, you've got such a long career ahead in this space, and to see you making such enormous inroads and with all the work you're doing leading the Australian chapter of Society of Cannabis Clinicians, and all the work that you do in educating doctors and the public and clinical practice. We're big fans, and we were delighted when you said you'd come on. So it's been a great chat. I feel like we might do this again if everyone's in for another one.
Andrew puts him on the spot right at the end to make sure.
Always
exactly.
it's a feature.
No, look, thanks so much for having me, guys. I mean, you're far too kind. And look, I love the work that you're doing and getting the word out, and certainly having that sense of community and sharing of ideas. There's no harm that can come from it. So awesome. Thanks again, and it's been great.
Been a pleasure.
Thanks so much. We'll speak again soon. Take care.
No doubt.
Cheers.